All right, now we're recording. So, welcome and thanks for joining me to talk about some of the concepts for medical students in neurology as it pertains to the NBME exams and the neurology clerkship. So, and thanks for putting those questions together. It's good to be here.
Yes, good to be with you, Dr. Bhatti. One of my questions was on neuromyelitis optica. It came up briefly when studying and also while on clerkships, but I don't have a great explanation on it. So if you don't mind just touching on a little bit about the pathogenesis and some of the typical symptoms seen in NMO.
Yeah, so I'm going to start by going a little back and creating a context around NMO. So NMO, neuromyelitis optica, is a demyelinating disease. What it means that the nerve cells, as they run, the axons, the long part of the nerve, is covered by another specialized cell that creates a thick covering, which is typically like a cell bilayer. So the two outer sides of the cell layer come together, join together, and then starts wrapping around the axon. And the main purpose was is to protect the axon, but the big advantage of doing that is that now the nerve axon is not leaky throughout the nerve axon, throughout the length. If it had to leak for the sodium and potassium to create a current all along the axon, the amount of sodium needed and the energy needed would have been 1,000 times more, and the process will be much slower. So what the nature has done is that it has made the conduction of electricity along the axon very fast and energy efficient by creating these coverings which have holes in them or gaps in them. And those are, and that covering is called myelin. It is a very special lipid bilayer and is created by a very specialized cell. And those cells are different in the brain and in the periphery. So in the brain, they are the Schwann cells. And now there are diseases which attack that myelin covering of the axon and causes damage, and we call them demyelinating disease. They don't do anything to the axon, so axon is fine. But once you lose the myelin, the axon becomes dysfunctional. It cannot conduct effectively, and it needs a lot more energy and often dies if the sheath is completely gone. But if it survives and if no recurrent damage happens, the sheath can come back and the axon can survive and do fine. Now, that attack on the nerve cells, now let's talk about that. The most common reason to have an attack is what we call MS, or multiple sclerosis. And in multiple sclerosis, the attack is happening through T lymphocytes. So if you know your immunology, there are the B lymphocytes and T lymphocytes. So the B lymphocyte are the ones that produce these immunoglobulins. So they secrete a protein. Protein goes and attaches to a target and attacks it. So we call it immunoglobulin based or protein based immunity. What the T lymphocyte does is that it activates other cells to go attack, like macrophages and other cells like that. It can also activate B lymphocytes too. But that kind of immunity is called cellular immunity or cell-based immunity. Now, multiple sclerosis is a problem of cell-based immunity. So it's the T lymphocytes activating cells causing damage to the myelin cell. That's why there is no antibody test for multiple sclerosis. You cannot do a serum test and say that this is the antibody that's high, because there is no antibody. It's the cell activation and cells damaging the myelin sheath. So that's why you have to diagnose either clinically or imaging criteria and so on and so forth. Now, neuromyelitis optica is also a demyelinating disease. It is considered within the category of MS-like disorders, but there are some major differences. Now, on imaging, without knowing the whole detail, it may look very similar to MS. And I might touch on it later on if this is something that's tested. But the most significant underlying difference is that NMO is a protein-based disorder. So it's an antibody-associated disorder. So the exact antibody that we have identified is called aquaporin 4 or IgG4 for aquaporin, and it basically is a special receptor or special channel on the myelin cells which gets attacked by this antibody, and that causes the NMO. Now, there are clinical differences. I'm happy to touch upon that if that's necessary, but that's the essential difference between NMO and multiple sclerosis.
Okay, thank you for that. So yeah, because I have the understanding that in terms of the clinical picture, they can present pretty similarly. Is that true?
Right. So the NMO has classically two areas of damage, optic nerve and spinal cord. And of course, both of them also are very often damaged in multiple sclerosis. I think 20 to 30% of patients with MS, their first attack is optic nerve, optic neuritis. Now, what are the differences then if NMO also has the same area? The clinically, one essential difference is that NMO almost never attacks any other part of the brain. So the brain is spared, which is never seen in MS. MS requires a criteria where you have some in spine, some in brain to classify it as MS, while that classification will never diagnose NMO because there is no brain involvement, except for optic nerve, which is considered part of the brain, but that's an exception, and it's all spinal cord. So that's the biggest difference. Another big difference, often the damage to the spinal cord that we call transverse myelitis, or inflammation of the myelin, which is the spinal cord, in transverse fashion. The transverse myelitis is seen in MS and seen in NMO. Now, how can you look at transverse myelitis patient and say, is it NMO or is it MS? And the difference there is, and I don't know if how absolute it is, but the major clinical difference is that the MS attacks in spinal cord are small lesions. There may be many, there may be 2 or 3 of them or 4 or 5 of them, but each individual lesion is small, and we typically call it less than 1 vertebral breadth height or vertebral height. So if there's a vertebra next to the lesion and look at the vertebral height and you look at the lesion should be equal to or less than the vertebral height. While the NMO, when it attacks the spinal cord, the lesion is long and often more than one, but it's often 3, 4 vertebral heights or 5 vertebral heights. So it's a longitudinally extensive lesion. And sometimes we also call it LETM, longitudinally extensive transverse myelitis. And the idea is that when it hits the spine, it's not going to just hit a small spot, it's going to hit a long segment of the spinal cord. In optic nerve involvement, the difference is less clear in terms of NMO, but it will be rare to have NMO just with optic nerve involvement without any spinal cord disease.
Okay, thank you for that explanation. So as you mentioned, they both affect the spinal cord and the optic nerves, but there are some pretty substantial differences in terms of imaging, as you mentioned, with the brain, as well as spinal cord imaging, longer segments versus shorter. And then also I imagine you can do like a lumbar puncture, and with NMO, you might see the antibodies against the aquaporin 4, whereas MS, you wouldn't see that. So that's another way to sort of distinguish them.
That's correct. Now in MS, well, we're not touching on it directly, but in MS, we look for elevated, what we call oligoclonal bands in the spinal fluid. And just so that nobody gets confused, those oligoclonal bands in the CSF are also antibodies, but they are not any specific antibody. There's a general increase in the number of antibodies in the spinal fluid. And what we're looking for is a mismatch. Normally, and the source of antibodies in the spinal fluid is serum, blood. So if you have 5 or 6 types of antibody in spinal fluid, you should have 5 or 6 types in the blood and in any infection or inflammation. Now, when you have 10 types of antibodies or 10 bands in the CSF, but only 4 or 5 in the serum, that means that the CSF antibodies are coming from the brain, not from the blood anymore. And that mismatch is one of the features of MS, but is not any particular essential antibody. It could be any antibody. It's just a generalized acute phase response. But oligoclonal band presence in CSF is one of the diagnostic features of MS. So those are antibodies, but they are not the one causing the Schwann cell damage or demyelination. And they are just there to show that there is some inflammation in the brain.
Okay, that makes sense. Thank you. I guess my last question is just, since they're both immune-based, are the treatment sort of recommendations pretty similar between the two, or is there some big differences in how these conditions are managed?
there is some similarity and then there are some differences. Um, the the big similarity will be steroids. So whenever there's an acute inflammation anywhere in the neurexis, you use steroids to immediately stop the inflammation. It's the best treatment to stop the inflammation right there, and immune response. So in an acute attack, you use steroids both for NMO and for MS. Now, where the difference starts is that in MS, there is a series of different medications that are designed to prevent further attacks. And those are all targeting the cellular immunity, the T lymphocyte mechanism, CD4, CD8. So it's not going to work on NMO. So those MS treatments that we use are not useful for NMO. Now in NMO, you need some time ongoing immune suppression to prevent further attacks, but there is no NMO specific medication, but there are other stronger immune medications that we use, for example, in cancer patients and transplant patients that have been also used in NMO. And in general, NMO responds poorly as compared to MS for immune suppression.
Okay, thank you. That's all the questions I had. I think you did a great job explaining. Coming in, I had sort of this idea that NMO and MS are very similar, and they can be, but you pointed out some important differences that can help you tell them apart clinically, but also, the way they're managed, how you can diagnose them. So I appreciate you taking the time to explain that.
Awesome. It's my pleasure.